Hello everyone. Today's video is on 20 PYQs from the topic of hematology from the subject of pediatrics. Your first question is most of the ALL are of, your options are B cell origin, T cell origin, NK cell origin and none of the above. The answer here is B cell origin because nearly 75% are of B cell origin, T cell is 5 to 10%. So most ALL is of B cell origin. Chloroma is seen in acute myelogenous leukemia, and this is also called, chloroma is also called as granulocytic sarcoma, right? Granulocytic sarcoma, that's what chloroma is also called, and it is seen in AML. Transient myeloproliferative disorder of the newborn is seen in association with, your options are Turner syndrome, Down syndrome, Marfan syndrome and Klinefelter syndrome. So this transient myeloproliferative disorder is seen in Down syndrome. Okay, 10% of newborns with Down syndrome can have transient leukemia, which is this transient myeloproliferative disorder of newborn, and that can present with anemia. Okay, anemia. It can present with thrombocytopenia, can present with high blood cell count and blasts on the peripheral blood smear, and HS megaly, hepatosplenomegaly, like a leukemia. It can present with this bicytopenia and high counts and blasts on smear and hepatosplenomegaly. So this transient myeloproliferative disorder of the newborn is seen in Down syndrome. A 5-year-old well-looking boy comes with overnight petechial spots. 2 weeks back he had abdominal pain. There is no hepatosplenomegaly. Probable diagnosis is, so your options are acute lymphatic leukemia, aplastic anemia, ITP, that is immune thrombocytopenic purpura, and acute viral infection. So what are your clues here? So you see that he's a well-looking boy, that means he's not looking sick, and there are overnight petechial spots. Okay, sudden onset, and 2 weeks back he had abdominal pain. Probably that was some infection, or even this could also be a clue to Helicobacter pylori also. Okay, there are some studies that show that that may be associated with ITP. And the most important clue here is there is no hepatosplenomegaly. Okay, now if there is no hepatosplenomegaly, they are trying to tell you that you can actually rule out acute lymphatic leukemia, and you can also, since he is well looking, it's probably indicating that there are no other symptoms of sickness, so you can rule out acute viral infection as well. No hepatosplenomegaly. Okay, aplastic anemia as well as ITP both will have no hepatosplenomegaly in the ideal setting. Okay, so and this 2 weeks back he had abdominal pain. This is indicating some underlying illness at that time, following which the child is having ITP. And overnight petechial spots, this is very typical of ITP, that a well child has sudden petechiae purpura bleeding into the skin, right? So ITP is the answer. Aplastic anemia, you usually won't have a well looking child. There will be pallor, right? And there will be some clinical findings as well, which are actually not going with the findings described here. Okay, so the most likely answer here is ITP, not aplastic anemia, leukemia or acute viral infection. 7-month-old baby with severe pallor and hepatosplenomegaly. Similar history with the sibling. Investigation of choice is. Now this is 7-month-old baby and has presented with severe pallor and HS megaly, right? And the sibling is also involved. Now investigation of choice among the options of bone marrow biopsy, HB electrophoresis, HB estimation and platelet count. Of course you are going to do an HB and platelet count to look at the actual values, but what's the investigation of choice? In this baby you are suspecting what? 7-month-old, after the first 6 months what happens? Fetal hemoglobin starts reducing, right? And severe pallor, hepatosplenomegaly, which occurs in the second half of infancy, right, likely points towards beta-thal major, right? This is very typical history that after 6 months of life, in the second 6 months in infancy, they can present with progressive pallor and hepatosplenomegaly. And similar history in siblings suggests that the sibling also has a similar involvement, which could be beta thal major. Investigation of choice here will be HP electrophoresis, because you want to know the hemoglobin type that is raised, right? So beta thal major is the current clinical diagnosis we are considering, and electrophoresis is the diagnosis, or sorry, investigation of choice. Fanconi anemia is, your options are hemolytic anemia, constitutional anemia, iron deficiency anemia, and autoimmune anemia. So we all know that Fanconi anemia is classified into constitutional anemia, right? Constitutional pancytopenias. So this is clear. This is a clear-cut answer. It's constitutional anemia. Patient has ecchymosis and petechiae all over the body with no hepatosplenomegaly. All are true except. Now again here there is no hepatosplenomegaly and the patient has ecchymosis and petechiae. All are true except increased megakaryocytes in bone marrow. So first of all, what are we looking at? We are looking at ITP over here as the clinical diagnosis, right? Ecchymosis and petechiae and no hepatosplenomegaly. So in ITP, what all do you expect? Increased megakaryocytes in bone marrow? Yes, this is a typical finding. Bleeding into joints? Not really. Usually they have skin and mucosal bleeds. There is petechiae, purpura, ecchymosis, there is epistaxis, there may be menorrhagia, right? So bleeding into joints is not a typical finding in ITP. Decreased platelets in blood, yes, the name itself says thrombocytopenic purpura, so decreased platelets in blood is correct. Disease resolves itself in 80% patients in 2 to 6 weeks. This is also right. Some patients may recover even without treatment. So this is also right. So what's not true? Bleeding into joints is not a typical feature of ITP, right? Absent thumb, radial deviation of wrist, bowing of forearm with thrombocytopenia. Which investigation need not be done? Now you can see in this picture clearly, right? Hypoplastic thumb is there. There is radial deviation of the wrist, right? Which investigation? First of all, what are you looking at here? What are we suspecting here? We are suspecting Fanconi anemia here, right? We are suspecting this particular clinical entity in this scenario of what is described here. Which investigations need not be done? Now your options are echo, bone marrow, platelet count, and lymphocyte chromosomal breakage study. Now this study, this is the thing required for diagnosis. So lymphocyte chromosomal breakage study you are going to do because you are suspecting Fanconi anemia. Platelet count, you are going to do a complete blood count, which also includes platelet count. Bone marrow examination, yes, because you want to look at the hypoplastic marrow, right? You want to look at the bone marrow findings. Echocardiography is not an essential feature immediately into the diagnosis, right? So the best option among all the given options here is echocardiography. Echo is not the immediate investigation to be done in this child. In Glanzmann thrombasthenia, there is defect in, this is again a one liner, we all know that there is defect in platelet aggregation in Glanzmann thrombasthenia, right? There is defect in platelet aggregation. The other options, platelet adhesion, decreased ADP release, and disordered platelet secretion, are wrong. Glanzmann thrombasthenia is the defect in platelet aggregation. Drug which may lead to hemolysis in a child with G6PD deficiency. Options are penicillin, primaquine, ceftriaxone, and erythromycin. We all have the list of drugs which should not be utilized or which should be ideally avoided in G6PD deficiency, and primaquine certainly should be avoided because it can lead to hemolysis in a child with G6PD deficiency. Constitutional pancytopenia can be seen in all of the following except Fanconi anemia, Diamond-Blackfan anemia, dyskeratosis congenita, and Schwammen-Diamond syndrome. So which can constitutional pancytopenia can be seen in Fanconi, dyskeratosis congenita, and Schwammen-Diamond syndrome. These are classified into constitutional pancytopenia syndromes. Diamond-Blackfan anemia is not classified into constitutional pancytopenia syndromes. although it is also a bone marrow failure syndrome, but it is not classified into constitutional pancytopenias. Which of the following is generally not seen in immune thrombocytopenic purpura? Okay, what is not seen? Okay, males and females are equally affected. Yes. Petechiae, ecchymosis and bleeding. Yes, this is also seen. Palpable splenomegaly. No. Increased megakaryocytes in the bone marrow. Yes. Okay, palpable splenomegaly is not a typical feature of ITP. So if you have a child who has come with a clinical picture of ecchymosis purpura and you notice that he has splenomegaly, he has bone pains, right, he has pallor, those are atypical features and that should definitely make you reconsider your clinical diagnosis. So palpable splenomegaly is not seen in immune thrombocytopenic purpura. If you find that, you have to look for other causes. The following are features of beta-thalassemia except bone marrow hyperplasia, hair on end appearance, splenomegaly and increased osmotic fragility. So we all know that as a result of inadequate or inappropriate hemoglobin synthesis, there is splenomegaly, right? There is hair on end appearance and bone marrow hyperplasia, both in beta thalassemia, right? Due to ineffective erythropoiesis. Increased osmotic fragility is not a feature of beta thalassemia, it is a feature of hereditary spherocytosis, right? It's a feature of hereditary spherocytosis. So all the others are present in beta thal except increased osmotic fragility. Feature of hemorrhagic disease of newborn. Again, we all know that this is due to vitamin K deficiency, prolonged prothrombin time. This is a one-liner. Prolonged prothrombin time is the feature of hemorrhagic disease of newborn. The other answers, defective platelet count, prolonged bleeding time, and prolonged thrombin time, these are not the right answers. Platelet count may be normal in this, but prolonged prothrombin time is the typical feature in HDN. True about Bernard-Soulier syndrome are all except thrombocytopenia, deficiency of von Willebrand factor receptor on platelet membrane, prolonged bleeding time, and inheritance is autosomal dominant. So now in Bernard-Soulier syndrome, thrombocytopenia is a feature. Deficiency of von Willebrand receptor on platelet membrane, yes, this is a feature. Prolonged bleeding time, certainly this is a feature in Bernard-Soulier syndrome. Inheritance is not autosomal dominant, it is autosomal recessive. Okay, so Bernard-Soulier syndrome is autosomal recessive. Okay, so all the others are true, the last one is not. The commonest mode of inheritance of von Willebrand disease is autosomal dominant. This is again a one-liner. They have asked commonest mode, although it can be inherited autosomal recessive also, but the commonest mode of inheritance is autosomal dominant. Glanzmann thrombocythemia is what? Congenital defect in platelets, in RBCs, defect of neutrophils or clotting factor deficiency. We all know that this is congenital defect in platelets, in platelet aggregation particularly. Major source of von Willebrand factor is erythrocytes, neutrophils, endothelial cells and monocytes. So major source of von Willebrand factor is, we all know this, it is endothelial cells. True about iron deficiency anemia is all except. Okay, so in iron deficiency, microcytic hypochromic anemia, yes. Decreased TIBC, no. In iron deficiency, there is increased TIBC, right? Reduced ferritin, yes. In iron deficiency, ferritin stores are reduced, levels are reduced. Bone marrow iron reduces earlier than serum iron. This is right. Bone marrow stores are depleted before serum iron starts coming down. So true are all. What are these true statements? Microcytic hypochromic anemia, reduced ferritin, and bone marrow iron reduces earlier than serum iron. Okay, decreased TIBC is not true in case of iron deficiency. And your last question is secondary causes of pediatric polycythemia. Congenital cyanotic heart disease, high altitude hemangioma. So this secondary causes of pediatric polycythemia, this polycythemia is in response to chronic hypoxia, right? So this can occur in cases of hemangiomas, high altitude, and in congenital cyanotic heart disease. So the answer here is all of the above. I hope these 20 questions on hematology have helped you, and drop your comments below and let me know which topic should we do next. Happy studying.